If I could ask you to all take your seats. So, welcome back to those who have been here since the beginning of the afternoon, and welcome to those who have only just been able to join us, particularly to the family and friends and colleagues of our inaugural lecturers. We've listened to a wonderful lecture from Professor Angie Wade, and we're now shortly going to hear, I'm sure, an equally wonderful lecture from Professor Alistair Sutcliffe. So to briefly recap, for those who were not here earlier, I'm Ros Smith. I'm the Director of the UCL Institute of Child Health. This is a really important event for us. These inaugural lectures are not only the most important, but in my view, the most enjoyable lectures of our whole programme here at ICH, because what we're doing is celebrating a fantastic achievement, the achievement of a UCL professorship, and that is no mean feat to attain. It requires years of hard work, diligence and commitment, and of course a great deal of talent. So after Alistair has given his lecture, it will be followed by a vote of thanks from Professor Brent Taylor, Emeritus Professor of Community Child Health here at the Institute of Child Health. And then after Brent has given his vote of thanks, I would invite you all to join us for some refreshments on the balcony in the Winter Garden. So it's my pleasure to introduce Professor Alistair Sutcliffe, who graduated in medicine from Manchester in 1987, and shortly after this commenced training in his chosen specialty of paediatrics. In 1995, he came to London to Queen Elizabeth's Hackney, who many of us remember fondly, and the Royal Free, where he became a senior lecturer in 2001 and then joined this institute around about 10 years ago. He was promoted to reader in 2011 and then to chair last year. Now, much of Alistair's work has tackled the very important topic of whether assisted reproductive technologies, particularly in vitro fertilization, cause any long-term adverse consequences in the infants who have been born following assisted reproduction. So I was a medical student when Steptoe and Edwards conducted their groundbreaking research, and it's very hard to believe that there are now 4 million children born annually following such procedures. And Alistair's work is very important to the families of those children, and he's used international and national databases to identify whether problems such as congenital anomalies or malignant diseases are more likely to occur in those children. And from what I've seen of his results, they are generally very reassuring to the families, but I'm sure he'll tell us more. He's also had a major interest in the long-term safety of medicines for children, and of course when you give a medicine to a child, long-term safety is the rest of that individual's life, which is many, many decades. And Alistair has also conducted and led on a number of important clinical trials. Alistair also makes an important contribution to teaching at the Institute of Child Health, and we've heard a lot about teaching from Angie, and he's deputy head of the undergraduate clinical course in paediatrics, and he's been awarded a number of accolades for his excellence in teaching. Now, on a lighter note, I'm aware, because I've seen it, that Alistair turns up at meetings in his unprepossessing cycling garb of neon jacket, tracksuit bottoms and cycling clips, which he sheds, Superman-like, to reveal underneath his sartorial splendour of sharp suits and silk ties. So, and we all enjoy such a colourful individual at meetings. Alistair also has his own website, which reveals a number of intriguing details about his interest in life outside medicine. I shall simply refer you to the website rather than expanding on what the content is. So it's an enormous pleasure to invite an outstanding clinician scientist, Alistair Sutcliffe, to deliver his inaugural lecture as a UCL professor entitled Academic General Pediatrics in the 21st Century, Continuing a UCL Tradition, Evidence from a Clinician Scientist. Alistair.
Thanks very much for that very generous introduction, Ross. And thank you to the audience for making the effort to show. I think the first thing I should do is try and define general paediatrics, because it doesn't always naturally lend itself to being regarded as an academic specialty. So in the clinical side, it's care of children under the age of 19 years. It doesn't involve neonatology, premature children, except when they come to us in some other role. And at least at University College London Hospital, my main clinical base, it's less adolescent, but some of us can look after adolescents too. I've been asked to talk very briefly about my personal life, so I'll keep that to the absolute minimum, and career, how I got there. Well, that was already summarised by Professor Smith. But what I've done is I've chosen a series of brief overviews of area where I have acquired and indeed profess knowledge, which I hope will be interesting to the audience. And at the end, I'll share a few thoughts on the NHS, which I'm also very committed to. It was the late Brian Clough, I'm just getting some water, the late Brian Clough, who was asked what's the secret to human happiness. And he summarised something which a lot of other people have realised is probably a universal truth, and that was that he said, you can't beat family life. Duck, because he's from the Midlands. And I thought that was very, very astute, and of course I have a family outside of my work looking after children, so I've got a few pictures of those. Career-wise, I come from the northwest of England and went to Manchester Medical School, and I came down to London just over 21 years ago, so I'm kind of an honorary Londoner. I trained up there mainly, although as a child I did also live abroad in a place called Newfoundland, which I would say has little to recommend it. I also had happier times travelling to and from Kenya, and it's a beautiful country that's sometimes bothered by some of its own residents. But I'm pleased to say that it's got better governance at the high levels now, and its standard of living is going up. So that's a really beautiful country, which I wish to return to with my family at some point. So, the family, just a few quick pictures. As you can see, I've changed very little. This was last year in Taiwan. The loss of hair. This is my team think I'm working there. And in fact, these are the paddy fields, which I've not seen before. I met this beautiful young woman who looks exactly the same today, of course, my wife, Norhan, who is a rheumatologist working in East London. And these are just some family pictures. She thought she'd be the biggest, but he's outgrown her. That's in Istanbul. This is my son, Jan. And that's us very recently on a trip to Turkey, where my wife's from. My Turkish family are also represented here today because my brother-in-law's come over for that occasion. And this is particularly happy. This is the final family picture. And this is my lovely mum and dad who brought me up on the day that my eldest got first and graduated from Cambridge University and then went for a fully paid year scholarship to Harvard. So she's done the family proud and set the bar very high for the younger two. And this is my lovely mother-in-law and father-in-law. I popped in on them once when my wife wasn't watching me because I was giving a talk in southern Turkey. And I'm very, very fond of them. They're great-grandparents. And in fact, my mother-in-law, I haven't spoken to her for 20 years because I didn't want to interrupt her. And so I don't forget, just to give credit to my main mentors, Professor Brent Taylor, who's speaking after me, who's taught me a lot, and I often quote. Professor Geddes Skrzynskis, who's a fertility specialist of international fame. Disappointingly, I can't see his face just yet here. Ted Melhuish, who's a professor at Oxford and has been at Birkbeck, and my main international collaborator, Professor Maryse van Duel, who's a Belgian. I have strong associations with that country, and I'm very pleased to see a couple of Belgian visitors up at the back there coming over for this occasion. And also to mention the people who've sponsored my research over the years. These are all large organisations, most of which are well known, and the Sir Harley Stewart Trust were very good because they gave me my first ever grant and are continuing to give me occasional support. So, now then, let's just switch to the, I think the person at the back's gone to sleep. Right, so I'm going on to the main content of the talk now, and I doubt if you'll see another professor coming to a talk with a roulette wheel as their main modus of delivering their talk, but there we are. So this isn't a dartboard, it's a roulette wheel, and I wish to use it as a vehicle for showing windows of my mind in a sort of manner of speaking. So let's give it a spin. And obviously roulette wheels are pretty random, so I'm a bit superstitious. I don't think we'll have 7 today. So let's start with 5, shall we, and see what that little window brings up. So fancy that, children born after assisted reproduction. I do know a little bit about that, and so I want to give the briefest overview of this very large topic of my research, but there will be other things after that, so I promise you won't get bored. This is a quote I'm going to show you, and it struck me as rather profound, and I've made sure that the person who said it has travelled all over the world, because I've given talks on fertility outcomes all over the world, e.g. Taiwan, e.g. Hong Kong, etc., etc. But what's really striking about this famous person is their name is, I only know them as Dave, and they're a taxi driver based in Nottingham. So Dave, by default, because they used to pick me up, and I used to go and see children there when I was doing my doctorate, he said, what are you in Nottingham for, Doc, or whatever? And I explained it was about the study that I do of a thing called, a thing called ICSI, intracytoplasmic sperm injection, its outcome. And he said, it's hardly a Darwinian way of reproducing. And I thought, this is a clever man who's somehow missed an education. But, of course, he's become famous because he's gone all over the world and he's even quoted in one of my textbooks on this subject. So I quote Dave. That sets the scene slightly. A little bit of background. Assisted reproductive therapies, we call it in the trade, so to speak, rather than IVF. And these are early human beings. This is a pronucleate embryo. This is what they do to freeze them. This is a thing called intracytoplasmic sperm injection, where a pipette 1/100th the size of a human hair injects a sperm straight into an egg. And that's not natural, it doesn't occur in nature, the sperm doesn't enter the egg. So some questions were raised about this technique and what might actually happen to the children thereof. This is called pre-implantation genetic diagnosis, where some of the cells have been taken away from embryo. This one I've forgotten, so I'll skip this one. And let's move on to a little demography to set the scene of the importance of ALT. In the UK, at the moment, the rate of ALT is about 1.9%. So couples, 2% of couples are having this as a way of having children. In Denmark, it's 5%. Figures are similar in France. And so as time has gone on, as Professor Smith pointed out, there are at least 5 million children in the world born after this, and it's a boon to the human race. However, fertility rates are falling, and it may well become even more used. Cost of ALT is going down, and availability and efficacy is going up. A present majority of couples who have it are older. Female factor is 70%, and the techniques can overcome some subfertility, but not all. But we, as doctors, we have a responsibility when we're studying patients to interact with them. So we have these high-tech things called, eyes, ears, and, So you guys probably don't know what that meant, but I'll just translate it. Whatever your mother works for McDonald's. Okay? And if you're interacting with young people, that makes a lot of contact, I assure you. Monta, loser, sucker, etc. And of course, I've got teachers who taught me that. So that's they're on the front row there, or second row, my 3 youngsters. This was one of them when they were young, just modelling for a system of development that I used. So she was 2 at the time, and she was sort of so precocious, she was kind of testing me rather than the other way around, which was a bit depressing. Little Ella, who's 15 now. I did some work in Manchester where it turned out I just... this is not doing well. Oh dear. I've really messed it up now. I'll be having to pay some bills or something. Just hang on. Sod it. Let's just get this one. Hello. Help me out. Help me. Help. I need a doctor. I've broken something. Come on. How about a roving mic? I'll have a roving mic. I'm really... Yeah, I can hold it. Yeah, okay, fine. Roving mic. Okay, so subbing in the roving mic. So after that, when I came to London, I did this big project looking at children who were born after this thing called ICSI, and then I did a European project. And I'm not going to bore you with all the data in it, but let's put it that way. It's the largest study that's been done of 5-year-olds with IVF conception, and we compared 3 groups, ICSI, IVF, and naturally conceived. Largest detailed study, I think that's the way to put it. And this is the kind of thing that we were getting out of it, data like this. Standard deviation score for length, notice it all merges towards the middle. Standard deviation score for weight, it all merges to the middle. And I'm very fond of a very wise expression, which is a kind of cheat for us paediatricians, which is growth is a bioassay of well-being. So these children were growing exactly the same as their naturally conceived peers, and obviously growth is a predictor of future health, so it was a very good thing to find. Here's an example of children being shown what IVF is in terms of freezing. This is in Belgium. My Belgian colleagues lent me this picture. And just in case they didn't get the point about the freezing, they just put a few penguins in there and a few polar bears and things just to make the point absolutely clear. Here's a brief summary of what's known about ART children today, and then we'll move to another topic. So in terms of perinatal outcome, babies are slightly lighter than their naturally conceived peers. They're born slightly earlier. They're more at risk of congenital anomalies, but not that much, about 1.3 times others. And in fact, Beckwith-Wiedemann syndrome was the first thing I managed to make a breakthrough with in recognising the association with ART 10 years ahead of anybody else. Neurological outcome, there may be a slight increased rate of cerebral palsy. I'm not totally convinced by that, and there may be a slightly higher risk of epilepsy. Certainly they're more likely to attend hospital, but that might be hospital-seeking behaviour because the families are quite concerned about their children. Other health threats, well, this is a good news message. Mature term babies born after ART progress healthily in relation to naturally conceived children. No concerns exist about the family relationships and psychosocial issues. We studied those in great detail. And there's little evidence about other health problems. However, it's an emerging field, and there may be long-term threats. Little reports come out from time to time which cause scare, and my phone rings, and I get approached by lay people in the press and so on. Could this be a problem? They're usually exaggerated when actually produced in any of the press reports. Other long-term threats, could there be a Barker effect, fetal origins of adult disease hypothesis on these children because they're smaller? Could there be a higher risk of cancer? I can address that question very shortly. There's some work I did with Dr. Williams. What about future fertility? Will these children have the same fertility as their parents, or will they have the same fertility as naturally conceiving people? Here's a fact. This is a powerful slide. It shows the rate of twinning taking off in the UK. And even more abnormal, look at this. And this is a bottom line about this part of my brief presentation, which is that the remaining main risk from having ART is higher order births and everything that comes along with them, which is implicitly unnatural. This is a rapidly changing field. There's all sorts of things being done. And here's a picture of a mouse. And this mouse is representative of a mouse which was created in the United States from a primordial follicle. This person, John Eppig, grew a primordial follicle into an oocyte, a mouse oocyte, I would stress, and then this mouse had a little childhood, and we'd call it a mousehood, I suppose. And they called this mouse Egbert, and Egbert grew up, but then when Egbert grew up, Egbert had a midlife crisis, dropped dead, put the mouse on the slab, and the child had osteosarcoma, diabetes, and all the rest of it. So this was quite a disaster, And I hope that that technology doesn't come to human beings sometime soon. I've written books on this topic. This is a little girl we were testing in Belgium. She's putting her hand up. She's really concentrating, listening to the hearing. Very sweet. And I have a message for fertility specialists, which I take all over the world. Please think of the children. And they do appreciate it, but whether they do it or not is a different matter. And it's translated into a variety of languages here: Italian, Dutch, Turkish, and so on. So that's the end of that little presentation. I hope it was interesting. So, moving on, the wheels needs a bit of oiling, so I think I'll just skip the wheel there. A rapid change of topic. I want to talk about a patient. This is the little girl in question, and she's looked after at University College London Hospital and another hospital. Indeed, I'm honoured to have her parents in the audience today. Now, this little girl, when she was a baby, she had a problem. And the problem was that she was the first child, and she was passing odd-looking stool. And the parents took her to a hospital several times, and they said, oh no, she's okay. She's all right. And unfortunately, she wasn't all right. So here she's in hospital. She's got a nasogastric tube. She's still a princess, as you can see. But she was very poorly. And what she had was a form of liver disease, which I've spent some time studying. And because the diagnosis was made late, she ended up having a liver transplant, which she's now got. And to me, a living hero is in the room today in the form of her mother, because her mother had to give half her liver to save her life, and the first person that did that in the world died. Fortunately, she didn't. So, I've been interested in this project for about 10 years, and when I think of this little princess, it motivates me to continue with what is a very difficult project to do, whereby we're trying to develop a reliable test which will recognize abnormal stool from normal stool. So thus, I've become a stool gazer. It's one of the jobs of a Professor of General Pediatrics. Okay? And it's known that there's an operation which can be done within 45 days, and that will reverse the illness, or rather mitigate it. But of course, if the disease isn't recognized by the abnormal stool, you're in trouble. And this is what happened to this little person. So we did this bench-to-bedside project, very in-trendy sort of phrase, just push it bench to bedside, called Billy Baby. And this is an ongoing project where we set out to try to ascertain an objective method of recognizing the difference between these normal and abnormal stools using a thing called spectrophotometer. That was what we came across after lots of cul-de-sacs trying all sorts of other different methods. In essence, it had been shown by some very disciplined people in Taiwan that it's possible to train an entire population to look at their baby shit and establish whether it's normal or abnormal. But that will not work in Knotty Ash in Liverpool, and it will not work in Newham. So that's not going to work in the UK, but it has been shown to work in Taiwan. So we wanted a technological thing for this stool gazing. The first thing we did was we studied staff in University College Hospital, Lewisham Children's Hospital, King's College Hospital, on the neonatal units, okay, nurses and doctors. I've got some of my nursing colleagues here today, which I'm very thrilled to see. And only 62% could tell the difference between a normal and abnormal stool. So a layperson's got very little chance of doing that. So we came up with this spectrophotometer. This cost £5,000. We started studying the poo. You see those two look differently on their little spoons. I wouldn't recommend eating them. And we had this eureka moment where we discovered that it is possible to distinguish between them. And that graph shows that with the biliary atresia on one side and the other children on the other side. So we subsequently collected another 200 samples, and we analysed those. Then we ran into some difficulty. And the difficulty was that nobody would pay for the next stage of the research. So in those circumstances, most people would give up, because I'd spent quite a few years doing this on top of lots of other things, but I'm a stubborn person. And I've approached the colour chemistry department in the University of Leeds, and they've come up with a totally different solution, or maybe I should say absolution to this particular problem. And we're going to be working on that very shortly. There's also something which I believe in passionately as a paediatrician, and that is we need to be kind to patients and families. And this little boy is called Hunter, and he's their youngest son. And I only saw him for one very specific reason. how would they believe that their other child hadn't got this terrible disease after everything that had happened to them? He's perfectly well, but I offered to see him purely because I think it's important that we're actually kind to people. He's a sweet little thing, isn't he? And that's the other patient as she is today. So, let's see what we're going to come up with next. Ooh, it's got a mind of its own, that thing. Right, moving on. Another topic. Health of children born to older mothers. This has become relevant because these days a lot of people are having babies later, and I was asked to speak at a congress on this subject, and I realised through the literature nothing was known, virtually nothing at all, nothing published in this area. It's a modern phenomena. People are having children later in life, and the numbers are going up fast. So I got together with some clever colleagues such as Ted Mulhewish, who's in the audience, and we came up with a project which was designed to look at health outcomes in these nominally ladies over 40. You'll notice that graph there. When I graduated, an elderly primep was somebody over 30 years of age. That's worrying to some of the women here, because nowadays the peak age for children in this country is age 30 to 34 years. So we did this project funded by the Wellcome Foundation, and we started to look at existing data. And it proved an interesting contrast to this depressing slide. These are all scientifically verified facts about having a child later in life. And you won't even have time to read them, but they're pretty scary. I'm sure Melanie Davis, who's in the audience, is familiar with this sort of thing. Hi. So we looked at the two existing cohort studies which have been run out of Birkbeck and respectively the Institute of Child Health, the Millennium Cohort Study and the National Evaluation of Sure Start Study. And Sure Start is for the most deprived wards of the UK, and the protocols for assessment were very similar. So we looked at those, and we did all sorts of clever analyses of certain things, such as child admitted to hospital, child had accident. These are all portrayers of risks of health, child immunisations, whether they're complete or not, child's BMI, etc. And we effectively studied 1,100 children for those aged 40 or over, or less for the younger age. Cohorts disappear over time, and we did all sorts of fancy things here, which I'll just flash through because there's a statistician in the audience, so I don't want to be scared and get asked difficult questions. So, you'll notice a trend here. Child had accident, mother 40 or over, you'll notice it's going in one direction. Child had hospital admission, less likely to have a hospital admission. Child had immunisations, more likely to have immunisations. Child underweight, less likely to be underweight. Child might be slightly more likely to be overweight. Child has better vocabulary score. Child has greater ability with a picture similarity score. Construction. They all go in the same direction. They're all positive, every single one of them, virtually no exception. Mother judged herself to be more self-efficacious. Mother's total support score. Mother was less disciplining, which is thought to be harmful to children, excessive discipline. So this is a positive. Household chaos was down. Learning environment was better. Father's involvement was slightly less. Okay. Mother's parental acceptance, responsiveness, etc., etc. These are all positives. So it was a really fascinating study to do. First of all, because there was a vacuum. Secondly, because what it showed, there was a striking contrast between what happens to mothers who are trying to have a child later in life and what happens when the baby's born. And remember, this was in both cohorts, the ones where mothers were from very economically deprived circumstances, as well as those from better off circumstances. So that's a brief overview of that, which I did with these lovely people. Dr. Julian Gardner was exceptionally good as our statistician. So moving on to the next topic, I want to talk a little about cancer epidemiology. And before doing that, I just want to refer to one letter. I get letters from all over the world, and I have, for the last 20-odd years, I've replied to them all, without exception, inquiring about things to do with IVF. So here it is, because this captures an idea which is very important. Dear Dr. Sutcliffe, I apologise for contacting you directly, but having just read an article regarding the risks of IVF in a daily newspaper, felt compelled to contact you. I'd like to include in a study I believe you're conducting regarding the risk of developing cancer in women who've undergone fertility treatment. I'm currently 42 years old with 2 children aged 6 and 4. My first child was conceived by conventional IVF in 2005, my second naturally. In August 2010, I was diagnosed with IDC breast cancer, which was ER positive, PR positive, HER2 positive. There's no family history of breast cancer. I'm a non-smoker and slim individual who drinks only socially. I've always believed that my diagnosis was linked to the IVF treatment. I was exposed to high levels of estrogen throughout the treatment, developed ovarian hyperstimulation syndrome twice in a short period of time. I firmly believe that further investigation into the long-term risks of IVF is urgently required. This is a multi-million-pound business and emotive subject, but women need to be better informed before making a decision that may ultimately provide a child, but not a mother. So, this takes me into a brief overview of another study which I've conducted with Dr. Williams and others in the audience. So, here we are. We did a study looking at the risk of cancer in children born after assisted conception, the colleagues mentioned there. And this was driven by parental concerns and uncertainty due to very small studies. And this is a painting done by a patient who got in touch with me fairly randomly at the age of 18 with her mother. And the reason why she got in touch is because she'd had eye cancer, retinoblastoma, involving one eye. Okay, notice she's portraying that, and she's put RIP. How did she get that retinoblastoma gene? She got it from donor sperm. And in fact, she's a very talented young woman, and this really does show her in some ways as how she appears, obviously not the multicoloured bit. And notice the devil's imagery there, and the fact that the sperm is lying over the child's face, or individual's face, and one eye is blocked out. So it's very tragic, and in fact, they'd still not come to terms with what had happened to them 18 years later. So, and they blamed the IVF process. So, we did this. We linked up the HFEA data set, which became available for non-anonymous research due to a change in an Act of Parliament in 2010, to this sad but fantastic registry which records all children 14 and under who have childhood cancer in the UK over this period. So we linked the two together. Doing the clever stuff was led by Dr. Williams in the audience, and Dr. Botting, and some other very, very useful colleagues who were very helpful. And the HFA were fantastic as well, and I've recently, for the past year, sat on their committee redesigning their entire data set, which was a great honour. We did the analysis, and we analysed the records for 106,000 children, which is quite a few, I think you could reasonably say, 700,000 years of exposure, and just to show you the sort of background of the paper we published on this thing, showing that there was nothing really different in the characteristics between the two. So we were thrilled, and in fact Dr. Williams got a European prize for this work, about the fact that you couldn't make it up really. The number of observed cancers was 108, the expected was 190.7. The standardised incidence ratio was 0.98, virtually 1. So we're very pleased about that. There were a couple of very rare cancers that was a slight increase. But overall, a great piece of work, very difficult to do. So watch this space, because we've also going to be producing some other research, pretty heavyweight stuff, which is in the process of being sent to the same journal. We're going to produce the donor data, the risks of Langerhans histiocytosis X. We're also doing this study, which we've just sent an abstract in and is about to be published soon, we hope, in some journal or other, of the 302,000 women exposed to assisted reproductive therapies involving 2.2 million women years. That's really not been done substantially. We're also talking about other cancers, and a separate paper looking at the mortality of women who've had ART, whether they got pregnant or not. And the motivation, remember, is that person who wrote to me. But there's another side to research, and the other side can be very, very frustrating. And I had this screenshot done for a reason. First of all, I wanted my albatross here to comment on it. So my albatross is going to comment on it, if the battery's working. You're supposed to quack. I've taught you to quack. So, you see, that shows a screenshot of 16 different documents, right? And they were filled in by Dr. Williams. And that was maybe only a third of the work to get this project off the ground. It's not for the weak and feeble. And what's really frustrating for me as a researcher is there's enormous overlap between those documents. A place came up on the organisation that runs this, and I was almost inclined to join it just to show them that screenshot, but I happened to be very busy. It was called PIAG. It changed its name to an equally original NIGB. Then after 12-hour session overnight, they came up with the name CAG. Really original stuff. And they're very, very frustrating. They have a purpose, but surely this isn't the way to do research if we're really going to do it well in the UK with our marvellous data sets. That was very, very frustrating to have to deal with all that stuff. All right, moving on. I just want to talk a little about something else which is really quite different, which I've been involved in. Children who are looked after by the state lack looked after children. They're not doing very well in the UK, and Professor Mel Hewish and colleagues showed me that this was important because we know that modern problems in children today include things like child abuse and neglect, school readiness, poor literacy, ADHD. These are all very, very important topics and things which I'm going to get more involved in the research of via the looked after children. We know that the outcomes in those individuals are really bad, and this doesn't make any economic sense whatsoever to have children in those circumstances who are coming out with all these problems as adults. So we approached the London Borough of Camden, and I was helped in that approach by Dr. Geeta Croft, who's in the audience, who's head of Looked After Children in Camden. And we said, can we have a look at your data? So we had a look at their data. Dr. Claire Tipper was very helpful, and Professor Jacqueline Barnes, and the analysis of this data done by Rebecca Smees. This is pilot data, but I thought I'd present it because I'm a great believer that not all research has to be in the New England Journal of Medicine. You can do things which also have value, which don't appear in those top journals. So we've reported this data in a congress, and the work is ongoing. But the fact is, LACs have a poor outcome, and so we wanted to look at the outcomes, the education, other outcomes in Camden, and to identify means of extending this analysis to the national data set. So I accessed this Camden data, and we looked at 50 variables for 949 LAC children over this period. This is digitally collected data. We looked at demographics, placement details, and educational outcomes. The sex ratio was the same, as you might expect. The ethnic mix of the children was resembling that of Camden as a whole. It wasn't particularly distinguished. However, just look at this slide. If you take anything away from this talk today, this is one of the most depressing things. Why does our nation allow this? One of the children in Camden during that time had had 42 placements. What chance does that child have having coming out of that happy as an adult? No chance whatsoever. And I've just met the head of the Coram Foundation, the world's first charity, and I'm planning to work with them. And the head of the Coram Foundation said to me, this is not extraordinary. 42 placements for one child. I think it's a tragedy, and I think our nation needs to deal with these things somewhat better. And I just thought I'd show it you because I think it's interesting. We've now managed to acquire the national data set. It's under lock and key in my office. And we've also managed to acquire a process by we study this data for children when they're not LAC anymore. They've gone back into society because that question is not being asked. So that's another project that I'm involved in with colleagues. Here's an example of their GCSE output. This one here. This is what Camden as a whole gets. You'll notice there's a striking difference between the two. This is what they're doing when they're over 16. NEAT doesn't stand for tidy. It stands for not an employment, education or training. And amongst the accommodation classes is Her Majesty's Prison. So there we are. Finally, before my wrap up, I'd just like to talk about another topic which I've been doing research on. And this is my work with Medicines for Children, which Professor Smith referred to before. So, when I had my interview for being made a tenured member of staff, I was told that I couldn't maintain 2 research themes. This was a bad strategy. So this slide's the answer to that, really. And I'm very pleased to see pharmacists from various points in my career, including Ian Wong and Steve Tomlin, very dear friends in the audience. So these are things which I've studied, and I'll make a brief reference to some of them. I was involved in the original development of the Medicines for Children network, led ably by Professor Smith. Okay? And I've been involved in medicines-related research for many years. medicines are 80% of all treatments in the NHS, so it seems appropriate a doctor might be interested in this. And in fact, I did an interesting little study, which I'd become a drug dealer, and these tiny, tiny little tablets are like the size of a saccharin. We managed to demonstrate that children as young as 2 can just take them like an adult can take adult tablets. And this was a highly cited piece of work. We also looked at a drug called domperidone, for which there's no evidence that it works in children. I keep telling my colleagues to see if it was safe. We've been doing some work on rickets and vitamin D with Dr. Basser Tamur, whose wife's just had a baby, so he can't be here today. And there's a problem with vitamin D deficiency in this country, which is growing fast. And this sort of thing, and also this sort of thing, which I've been quoted in the national press rather disproportionately recently, is resulting in vitamin D deficiency. If you put factor 8 on your baby, guess what happens? They don't get any vitamin D through the sunshine. And we human beings were actually, in this country, were generally ethnically in the past white, so that was okay. But darker skinned people, and people who have this stuff on, they end up getting vitamin D deficiency. I'm married to a rheumatologist, and she's smiling, because the fact is that if you've got vitamin D deficiency and you don't get your bone mass by age 25, you're going to get osteoporosis. So it's not as simple as just treat the rickets. That's the tip of the iceberg, so to speak. I've also been interested in drug errors, and I'll just tell a little brief anecdote. When I was a young registrar in Manchester, I got asked to see a child in A&E who was unconscious. No history, just gone into a coma. So I ran down to see them down one of these massive corridors, thinking, oh, this is great. Got there, child was in a coma, liver was enlarged, blood sugar was 0. So one of the nursing staff, because they usually help with my diagnoses, they know that, they won't admit to it. Remember, one good nurse equals 10 doctors. They love that one. They said, oh, maybe it's paracetamol. And there was no history of paracetamol overdose, so we took the paracetamol level and it was grossly elevated. So this child, I took them in an ambulance to Birmingham, which was one of the scariest things I've done in my career, and she subsequently died. And the reason is that her parents had misread the paracetamol bottle, and they'd been given just twice as much as normal for 4 days. This is a recent error I've seen at UCH, not involving our wonderful hospital, but community pharmacy. You can see what's happened here. They've got a label, 120 milligrams. Okay, but what's inside? 500 milligrams. So that child was being given 4 times the dose they're supposed to be given. So it continues, and it's important. I chair the Medicine Safety Committee at UCLH, and I'm very keen on that. I've done some work with Professor Paul Greengrass and colleagues looking at melatonin and seeing whether it's helpful to get children with developmental difficulties off to sleep. It was the launch project for the MCRN. It was a difficult project to do for lots of different reasons. And what we showed was that melatonin does indeed lengthen sleep, but not by the objective we intended it to. We also showed that it improved sleep onset latency. I've also been involved in this project, of which this lady here is in the audience, Sarah Curran. And this was looking at a rather depressing subject of whether suicidality, i.e. behaviours which may lead to suicide, were associated with certain drugs, and I was involved in various stages of that. And the subject that we eventually ended up studying within my team was a drug called Montelukast, which is used for allergies. And I was very lucky that Bob Boyle and colleagues at St Mary's Hospital, Paddington, helped with that study, looking at suicidality-related behaviours with Montelukast, of which there clearly are, and that's what's been demonstrated. The final one on the drug side is a project that's just started, and that project could be called the world's largest phase 4 trial. And I think it can be simply stated there are only 2 goals of most treatments: to help patients feel better or to help them live longer, or both. And in this particular project, we know, for example, no drugs provide health benefits without some degree of risk, and risk-benefit assessments require review as new data become available. So what are we doing here? We're essentially getting the public, as well as professionals throughout Europe, which has a population of 440 million people, to report drug side effects. We're using something in Britain which will be called the yellow card. That's going to be used in UCL Partners as one of the launch places for it. And then it's going to be tested against the data that we've got from that. And we're then going to collect that data, and it's eventually going to go to the EMA.
Professor Smith was very helpful in making sure that I was duly recognised for being involved in that project. So finally, I want to make sure that I thank my team and then just have a few words about the NHS. So Dr. Carrie Williams, Dr. Bev Botting, Dr. Nancy Bostock, Dr. Lamia Samad are examples of people in the audience. Put your arms up, ladies. And then I've got a number of other people. Emery, who's had a baby, he hid it very well. John Apps, who used to be in my team. And then we've got Pfizer, Afsal and Lisa Wong, who are with us on my European project, and a couple of other individuals who couldn't make it today. But finally, a few words on the NHS, and then I'll stop talking, and you can all wake up. Unlikely to be the case. So this is the first thing I ever published. So this is many years ago. I was working in Manchester, and you'll notice there's a big blob in the middle of that X-ray. That's a baby's heart. This baby was on the neonatal unit at St Mary's, and I was asked to see the baby because the baby suddenly, in the words of paediatrics, went off. Now, as it happens, I thought, ooh, this heart looks a little round and a little blobby. So I got, I was sweating at the time, I have to confess. I got the ultrasound and did an echocardiograph. I'd just been a paediatric cardiology registrar before that. And I saw this little heart beating away in this huge lake of fluid. I thought, oh dear, what am I going to do? So I rang the cardiologist who I'd worked with in the previous hospital, which was lucky I could get him, and he said, oh, do a pericardial tap. And he just told me how to do it over the phone. So I went and did it, and the baby's life was saved. Little did I know that I'd come close to seeing something similar to that at the wonderful hospital that I mainly work at, up the road, the chairman of the trust of which is here, Richard, welcome. University College London Hospital. One day, I was in the A&E about 7 years ago, and somebody came onto Tottenham Court Road, was doing something dodgy, a 16-year-old boy, and got stabbed in the heart. Fortunately, he chose to be round the corner from UCLH. He was brought in, he developed cardiac tamponade, and a junior doctor managed to crack open his chest, there and then, and stitch up his heart. Otherwise, he'd be dead. I saw him the next day. And you don't get that on ER, and that is absolutely heroic, and there's few hospitals I can think could achieve such a standard of care. But talking about standard of care, this is what I aim to do. It's on my website. I don't always achieve it, but I do believe we should be kind to families. And just some final comments on the NHS, really. Professor Friedman, who is the Nobel Prize winner for economics, simplified spending money into the following 4 categories. There are 4 ways in which you can spend your money. You can spend your own money on yourself. When you do that, then you really watch out what you're doing and you try to get the most for your money. That's sensible, isn't it? Then you can spend your own money on somebody else. For example, I buy a birthday present for someone. Well, then I'm not so careful about the content of the present, but I'm very careful about the cost. That's fair, isn't it? We all understand this simplicity. Then I can spend somebody else's money on myself. And if I spend somebody else's money on myself, like the Institute's paying for a nice dinner afterwards, nice food down there, so make sure you tuck in, team, then I'm sure going to have a good lunch. And then the final one, I can spend somebody else's money on somebody else. And if I spend somebody else's money on somebody else, I'm not concerned about how much it is, and I'm not concerned about what I get. Welcome to the NHS. These erudite statements define 4 kinds of spending in a way most of us can relate to, and these words show the fundamental problem with the NHS, unfortunately, and that it is the example of the fourth category. More neonatal intensive care costs? Yeah, we want them. Free parking? Yeah, why not? More expensive drugs for cancer treatment? Yes, please. Now, I don't know how many professors have bothered to thank their clinical team, but in my professorial unit we have these lovely people here, some of whom are actually in the audience. And they're being thanked for being great colleagues. They're all consultants I work with. Leanne Go is not there because she was appointed subsequently, but she's here today. So thank you, everybody, for supporting my work. And also, not to forget, somebody we lost, who unfortunately died. He was our colleague. He died young, leaving 3 children. So we miss Caro. And my last word of all is this. As a professor of paediatrics, why do I do it, and what am I going to do for the rest of my career, and indeed when I retire? Well, you realise, if you have children, that one of the things we have to do for them is provide security. And my work will be orientated towards helping the health side of that security. Thank you very much for listening.
Try not to jump about too much. Anyway, 1996 was a very good year for academic paediatrics at the Royal Free. It was decided that the medical school would merge with UCL, and more importantly, we were able to appoint a promising young, fresh-faced senior registrar, shortly afterwards upgraded to lecturer, Alistair Sutcliffe. Alistair immediately demonstrated uncommon zeal and enthusiasm and focus and commitment, each leavened with his particular charm and his particular humour, all of which he's illustrated in this inaugural lecture. So he tells me that the additional qualifications on his list were DBOB, don't believe your own bullshit, and PTO, don't please turn over. Anyway, Alistair then did the near impossible. He began and completed an excellent MD, at the same time as doing very well a busy full-time clinical job, making a major contribution to undergraduate teaching and developing an international reputation regarding the pediatric outcome of assisted reproductive techniques, especially in vitro fertilization. I was thus extremely happy to juggle various clinical consultant and academic sessions and various managers and have him promoted to a senior lecturer post, where he flourished and has continued to bloom, extending into other research fields while still maintaining his eminent position in reproductive medicine, artificial reproductive techniques. He's now published over 170 papers, has supervised numerous PhD and MD students, several in the audience, and has present research funding from the MRC, the EU, and CRUK, highly prestigious. He's also provided strong academic support within UCL, more recently at ICH, and on various national and international bodies. He continues to be an effective and popular teacher, and he remains a highly regarded clinician in general pediatrics at UCLH. Alistair's chair is in general pediatrics, and although he's made a very good case for the contrary view, in general, pediatric research, even in centres of excellence like ICH, general pediatrics is something of an undernourished, underachieving outlier, an orphan, even though general pediatric problems are what most pediatric patients suffer from, and an area where the UK is not doing at all well by international comparisons, suggesting much more research is needed. The discipline needs effective academics like Alistair to carry it forwards. So, UCL's Institute of Child Health has made a wise choice in promoting Alistair to this chair, where, with his intelligence, his ability, and his individual flair, he will achieve great things. Alistair, hiding behind the screen, on behalf of the audience, and particularly as previous supervisor and trainer, as a collaborator, colleague, fellow cyclist, and friend, I congratulate you on your achievements thus far, and thank you for your excellent lecture. Ladies and gentlemen, Professor Alistair Sutcliffe.